I welcome all. I'm Dr. Ankit Khandelwal, Faculty of Anatomy in our Auricle platform. And so today's topic is surface anatomy of few parts like lower limb, pelvis, and back. Well, a couple of sessions we have conducted before where the upper and lower limbs have been done. So today we'll be talking of the surface anatomy of the trunk, right, which includes our thorax and abdomen. So first of all, it's going to be beneficial not just for university exams, but also for your next or NEET, PG, INI, whichever exams you're going to get, right? These are the sort of questions that will be covered. So three area of questions are there. Mainly these are the long essay type questions, short essay, and the short answer type questions, right? So these are three varieties of questions which can easily be covered through these sort of sessions. Why to choose Auricle? Here are a few examples of it. Recorded classes, live classes. So 5-6 main points over here. Recorded classes, live classes, practical sessions are there, exam module is there, and hard copy book set is there. Apart from this, one-to-one doubt clearing sessions also there. In detail, we have each slide for each details of it, right? So we have all of this doubt clearing session and also these hard copy notes. And we have this Auricle app and all, right? We have few subscriptions. This is practical class. We have few subscriptions. I urge all of you to take the screenshot of it. We have subscriptions which are ranging from 3-month time period, which ranges from 3-month time period over here to 6 months to 12 months to around 4 years. And you can use the code also. Code is given over here. Code, you can use this one also, Dr. Ankit 20 over here to get some discounts on your subscriptions. Okay, take the screenshot of this. Moving to the topic straight away now. And the topic of our discussion is surface anatomy over here. So as said before, we will start with what? We will start with the thorax and then we'll come to the abdomen. So we'll start with thorax and then slowly we will come to the abdomen part, right? So as I've told in the previous two sessions also the importance of surface anatomy. So I urge those of you who are coming here for the first time for this surface anatomy session, kindly go back and look for the previous two sessions of anatomy on surface anatomy, particularly there the importance, the benefit of the surface anatomy is being discussed before actually the surface anatomy. For thorax, let me tell you the 2-3 main structures in thorax which we all know are the heart, which is present over there, another organ that is the lungs, and then there are some of the blood vessels and the coverings of heart and lungs are there. And all these structures over here are mainly used for the physical examination. When we go for physical examination, to hear for the lung sounds, breathing sounds, and for the heart murmurs, for the walls of the heart or cardiomegaly, there's so many things over there. So problems related to these two organs, a doctor, a physician should know basic surface anatomy at least of these two organs, which will be dealt in the thorax part. Okay, mainly these two. Other things are also there that we'll see that like some blood vessels will be there. So let's start without wasting any further time. Let's begin over here. So right brachiocephalic vein. Okay, before moving to the right brachiocephalic vein, let me tell you a bit of anatomy of right brachiocephalic vein of the venous system as whole. First, just it will hardly take a minute for you to understand the basic anatomy of the venous drainage, right? First of all, you should know that also. Just a minute over here. So what actually happens is that from the region of head and neck, over here, we have veins which are coming down on both the sides, and these are known as internal jugular veins. Okay. Then from the region of both the upper limbs, on both the sides, upper limbs, we have another set of veins that are coming towards the center of the body. What are they known as? They are known as the subclavian veins. What are they known as? Subclavian veins. Now, both these internal jugular and subclavian vein, they join to form what is discussed over here, that is a brachiocephalic vein. So brachiocephalic vein, we have to understand, is formed from where? Brachiocephalic vein is formed from the joining of the subclavian vein and internal jugular vein of one side. So right brachiocephalic vein is the combination of right subclavian and right internal jugular vein. The name brachio means upper limb and cephalic means from head neck. Similarly, the left brachiocephalic vein will be coming from the left internal jugular and left subclavian vein. So this will be our left brachiocephalic vein. We write BCV. And here you can see the questions like that the left brachiocephalic vein is crossing the midline. And both these brachiocephalic vein, they join to form what is known as the superior vena cava. Basic idea, this much should be clear. Okay, this much should be clear. And most of these structures over here, they actually behind the sternum and between the sternum and the rib joint of first and second rib over here. These are basically behind the sternum. So we don't feel them right over here. So we have internal jugular vein coming down like this, if you understand, from the side of the neck. We have the subclavian vein coming from the sides. Okay, coming from the sides, which are arching over the first rib below the clavicle. So subclavian vein from the side, from the shoulder area, you can just to understand. Internal jugular vein coming down from the neck, and they both meet over here and they form the brachiocephalic. That is the whole point. And both the brachiocephalics, what they do is they join and they both mix up onto the right side to form the superior vena cava, which goes into the right atrium of the heart, that we should know. This is the basic anatomy. Now let's understand the surface anatomy of it. Now surface anatomy should be a bit easy if you understood the basic idea of it. So this is what we are discussing, is the right brachiocephalic vein, right? Okay. So here we are seeing that this over here is internal jugular vein. This is the right-sided subclavian vein, and this over here is the brachiocephalic vein. So medial end of right clavicle and lower border of right first costal cartilage close to the sternum. So if I just try to show you the sternum, how the sternum is made, this is how the upper part of sternum, that is a manibrum sternum, then the body of sternum, and then the xiphoid process. We all can feel, okay, that here you have the clavicle, right? We all can feel the clavicle, it is subcutaneous. This is the point. So middle end of right clavicle. So this is point number one. This is point number one, middle end of right clavicle, but deeper, not over the bone. These veins are deeper to the bony structures. And then we should also know that at this joint, we have the second rib. Therefore, first rib should be over here. So brachiocephalic vein is from medial end of the right clavicle to the lower border of right first costal cartilage. So the second point is somewhat over here. This is the second point. If you join these 2 points, or you can say behind the right border of the manibrum sterni, behind the upper half of right border of manibrum sterni, is the presence of right brachiocephalic vein. This is the right brachiocephalic vein behind the bone. Okay, let's see the next one. Okay, join these by 2 parallel lines 1.5 centimeter apart. So join these by 2 parallel lines 1. Why they are saying 1.5 centimeter? That is actually the diameter of the vein, because all the blood from head, neck, brain, and the upper limb is coming. So it is a huge amount of blood. So the diameter or the girth of the caliber of the vein is not very small. It is a big vein. And that is the reason it is behind the bone. Okay, so it is 1.5 centimeter apart. Okay, let us see now the left-sided brachiocephalic vein. As I told in the beginning, focus over here. Where is the left brachiocephalic vein? Let me put some dots over here. This is the left brachiocephalic vein. I hope the point is clear. It is crossing the midline. That is also important MCQ. Let us see. So now the first point is middle end of left clavicle. So this is point number 1. And the second point will be again be where? Where the right brachiocephalic vein was ending. At the same place, the left brachiocephalic vein will also end. So you can see the second point is common. Lower border of the right first costal cartilage joined by a fine. So their second point is common. Right. So first point over there was middle end of right clavicle for right-sided vein. Here we have middle end of left clavicle. And then you join these two and you get the picture of the left brachiocephalic vein over here. Again, you have a gap of around 1.5 centimeter because the amount of blood will be approximately same on both the sides. Not much difference. Okay. Now both of them join to form what? Both of them join to form the superior vena cava. And where does it go? It goes into the right atrium. So where both brachiocephalic veins ended, from here, if I show with a different color, the SVC will start or not? Yes or no? So their first point is the lower border of the right first costal cartilage. So this is the first point of your SVC beginning. So SVC will begin from here, point number 1. Second point is sternal end. Now here, listen carefully. At the lower border of the first costal cartilage, we have the first point. Then SVC will go down behind the second costal cartilage, and then it will reach the third costal cartilage. And it will end where? Upper border of right third costal cartilage. It will end over here. Let me try to show you the diagram. Suppose this is the manubrium sterni. This is the body of sternum. Just be with me. This is rib number 1. This is rib number 2. That is rib number 3. Yes or no? Understand, lower border of right first costal cartilage is where the SVC will start. Then it will go behind the second costal cartilage, and at the upper part of third costal cartilage, this is where it will approximately end. Why? Because from here, let me tell you that also, from here, from this point, we have the beginning of the upper border of right atrium also. So from lower first to upper third. So SVC is from where? Lower first to upper third, L1U3. You can remember that as a pattern for memorizing. Just remember L1U3, lower first and upper third. Lower first means lower part of first costal cartilage and upper part of third costal cartilage. L1U3 will be your this. That's to remember where does the SVC lies. Above it lies the brachiocephalic, and below this will lie the right border of the heart, that is the right atrium. Simple as that. Draw a line 2 centimeter wide joining these. Now see, 1.5 centimeter was the diameter, but now SVC will be a slightly bigger, so they have increased the diameter from 1.5 to 2 centimeters. Now it is 2 centimeters. That's the whole point. Okay. So now we have reached where, if you look over here, then this is the second rib. Let me change to black color. This is the rib number 2. Rib number 2. Why? Because here you have the sternal angle. This will be rib number 3 over here. So SVC is ending over here. So from here, where the SVC is ending, begins the right border of the heart, mainly by right atrium. We'll see that also. Let us move forward. Now about the arch of aorta. Just to understand the arch of aorta is actually behind the manubrium sterni. Just for a layman understand that the arch of aorta, its surface anatomy, it is again where? It is again behind the manubrium sterni. It is behind the manubrium sterni. Arch. Now arch, if you see from frontal view, from front anterior, arch will appear like this. But we have to understand that suppose this is the beginning of the arch, we can say ascending aorta, and then it goes down as a descending aorta. From front, it will look like this, as you can see in the image also. But actually, it is going from where to where? Arch is going from anterior and it is arching. It is arching over the left bronchus, going posterior. So basically, arch of aorta is going anterior to posterior. So if you see the arch of aorta from a lateral perspective, now this was a frontal view. Think about it. We are looking from front as in the image. But if I tilt the body like this, suppose I move like this, so you will be seeing at a body from a left lateral position. So if I see the arch from the left lateral position, the arch will look like what? Arch will look like this. So it is going from anterior to posterior. So more anteriorly is placed over here, the heart is placed. It gives off the ascending aorta. And then there's this whole arch. It is going posteriorly to go down as a descending thoracic aorta. Okay. This is what we should know at least now. Looking at the points in the surface marking of arch of aorta. To begin with, we have what? A right end of a sternal angle. Sternal angle is what? Sternal angle is where the manubrium and the body of the sternum meet. So this point over here, this point is the sternal angle, also known as angle of Louis. So this is our sternal angle. So its first point is right end of sternal angle, point number 1. Second point is center of manubrium over here, second point. Third point is sternal end of left second costal cartilage. So left side is second costal. This is where the second rib starts. Rib is never attached directly to the sternum. It is always over here. What we have the costal cartilage. So its third point is sternal end of left second costal cartilage. Third point is somewhat over here. This is the third point. But it is a 3D image, you have to understand. It is not a small artery going like this only. No, it is a biggest artery, understand. It is a 3D interpretation. We have to understand this going from front to back. right? It is going from front to back. So as I told that you have to, for a layman, you have to understand that the arch of aorta is behind the manubrium sterni. Okay, these are the points. I hope the point is clear. Okay, let's move forward now. Trachea, very important. Why? See, all of these things will have a lot of clinical implications. The moment you begin to read about diseases, in first year, we read about diseases mainly in applied anatomy. We have 3, 4 lines over there, 4, 5 points. We just name a few common diseases, and that's all the beginning. It is fine. But as we reach the second year after passing first year, we have a whole subject like pathology, pharmacology, and we have the clinics around also. Then we slightly enter a bit more deeper into the diseases. As you are seeing over here, the veins and the arteries, no, they have their own set of whole pathologies. All these are used there. Okay, now we are seeing what we are seeing at the trachea. Now, trachea, most commonly tracheostomy, right? Just to save a life, we should know where the trachea lies. It is at the midline. Okay, trachea is where it is at the midline. 2, 3 things before looking into the surface anatomy. Basic anatomy you should know. Then we can delve into surface anatomy. We inhale through nose. Air will come through nose. It goes down. Okay, through nose it goes where? Behind the oral cavity to the oropharynx. Right. Then from oropharynx it will enter into the larynx. Then it will pass through the entire larynx. Then it comes to trachea. So we have to understand that trachea will begin where the larynx will end. And the lower point of larynx is the cricoid cartilage, which is roughly around the vertebral level C6. You can feel the thyroid cartilage over here with Adam's apple. Below this, we have the cricoid cartilage. So this is my cricoid cartilage in the camera, if you can see. So just below cricoid, I have over here my trachea, midline. And trachea anteriorly will have C-shaped cartilaginous ring. So once you palpate it, you will feel some resistance sort of structure. It is not a tube entirely. It is a half C-shaped hyaline cartilage is in front of it. So it roughly starts at around C6. And where does trachea end? It will end slightly below the sternal angle. So we all know why now. Where is the sternal angle? Between the manubrium and the body of the sternum. So roughly around there, a bit below, the trachea will then come down and bifurcate into 2 bronchi. Now let us see the points over here. First point, a point immediately below the arch of cricoid cartilage. I told you how to find the arch of cricoid cartilage. In the neck anteriorly, you have this Adam's apple, more prominent in males, but in females also we can palpate it. This is thyroid cartilage, not gland, thyroid cartilage. Now, just once you're able to palpate the thyroid cartilage, which is not difficult, you just go down and the next cartilage, which you will feel is the cricoid cartilage. Thyroid, below thyroid, we have cricoid. Again, saying thyroid and below thyroid, cricoid cartilage. Now, just below cricoid, what you have in the midline is the trachea, simple as that. Okay. Second point is what? A point 1.1 centimeter later to the center of the sternal angle. So yes, somewhere around the sternal angle we have, and then it bifurcates into 2. Draw 2 parallel lines around 2 centimeter. You should see it on your own. This is my trachea beginning. It is going down. Then this is my manubrium. Okay, this is my sternal angle. So somewhat around this. This is the approximate length of an adult trachea. Somewhat say around 10, 12 centimeter. Simple as that. Okay, we should know where the trachea lies at the center midline. It is a single structure at the midline. Sternal angle, as we have seen already number of times, sternal angle junction of manubrium sterni and the body of sternum. This we can palpate actually. If you're feeling at the bottom of the neck over here, the first bony structure that you feel below is the sternum. Once you start feeling sternum, come down for 4 to 5 centimeters, you will feel a transverse ridge. You will definitely feel, and it is subcutaneous. It is subcutaneous. That transverse ridge around 4 to 5 centimeters below the upper margin of manubrium is the sternal angle. So this becomes our sternal angle. Few points about it, let us discuss. Marks the position of the manubrial sternal joint. Fair enough. Posteriorly passes through intervertebral disc between T4 T5. Now, where is this useful? These are useful when you're seeing at a CT scan. Okay, so if you just elongate an imaginary plane, vertical imaginary plane through the sternal angle, at posterior part, it will bifurcate around between T4 and T5 vertebrae. Second rib articulate over here, as I already told you. And once you enter into the more anatomy, you'll see that superior mediastinum is separated from the inferior mediastinum. So it's an imaginary plane. We take from here, we take an imaginary plane that is going transversely from front to back. So second rib is attached on the sternal angle. Now this is a very important point because this is how the rib counting can be done. Because sometimes it might trick you that which rib am I palpating with. Suppose patients do come with the fractured ribs, broken ribs. And if you are able to palpate the ribs and you know the rib is broken, at least you should comment, na, it is a fourth rib, fifth rib, sixth rib, seventh rib, which is broken. Suppose you're writing fifth rib is broken, just assuming, now that won't help. Later on comes out to be sixth or seventh rib. What confidence will it give to you? Understand? Are you understanding? Because rib counting is very crucial. So therefore, we should know where to count the manubrium sterni, where is the sternal angle. So moment you reach the sternal angle, you move your fingers slightly outside lateral to it. This is the rib always going to be the second rib. Then you can count below third, fourth, fifth, sixth, seventh, and eighth, ninth, 10th, and so on and so forth. Rib counting, that is very important clinically. So landmarks, these are the theory points. Landmarks of what? Of the sternal angles. Not just what one or two things that we discussed. There are other things also which are happening at the level of sternal angle. I would ask you to take a screenshot of this and do read them multiple times. Arch of aorta begins and ends over here. Pulmonary trunk divides in pulmonary arteries. Thoracic duct moves. Trachea bifurcates. Now here, 2-3 things we already have discussed, like trachea, arch of aorta we have discussed, right? Azygous vein also opens. So yeah, take a screenshot of this and do read it for 3-4 times. You will catch up with this as soon as you do that other points over here. Now comes the heart border. Okay, heart borders are needed. Why? Once you are auscultating, you are doing a percussion examination. Person comes to you in casualty with a stab injury or a gunshot wound. Suppose there is a gunshot wound. You are seeing the entry point of the bullet and you are seeing the exit point of the bullet. Okay, you should be at least confident that, okay, is it close to the heart or is it too far away from the heart, so there won't be any issue with the heart. If the heart is normally placed like this, the heart is abnormally placed, things are different. But in normal person, if you know that the, okay, bullet is entering from this entry point and exit point is also at the same level posteriorly, you are sure, okay, the heart is fine. Getting a point? So you should know at least what are the actual heart borders. So now, how to see for the heart borders? Remember we discussed superior vena cava. What was the formula of it? I said L1U3 if you remember. Lower border of first cartilage, upper border of third cartilage. And I said there only that where it will end, what starts, the right border of the heart will start, which is basically formed from right atrium. Yes or no? Now you'll see. So heart borders. Let us see. At lower border of the second left costal cartilage, ½ inch. So you can remember it by ½ inch from the sternal margin. So starting from the left side. So these are the numbers. You can see the numbers. These are 1, 2. These are the ribs over here. 1, 2, 3, 4. On the left side, they are saying ½ inch away from the sternum. So on the left side, remember the point over here is your second costal cartilage. Then as you go down on the right side, upper border of the third right costal cartilage, 0.8 centimeter from sternal margin. Now, this is where the SVC ended. This is where the superior vena cava ended, upper part of third cartilage. And this is from where the right border starts, or upper border. We'll see. The point over here is to understand the heart. This is how the picture of heart will appear. Okay. So these are the points. A, B, C, D will be the points. This is the B point is your upper third. This is your second left costal cartilage. As you go down on the right side here, on the right side, we have the sixth cartilage, lower border of sixth right costal cartilage, 2 centimeter from sternal. So this is remember number 3 over here. Number 3 is your third costal cartilage. Number 6 is sixth costal cartilage. And they are very close to sternum, hardly around 1 centimeter from the sternum. So their length is around 1 centimeter approximately from the sternum, both this. This D point is a bit far away, we'll see. At the apex of the heart, at the left fifth intercostal space, 9 centimeter from mid-sternal line. So this is a bit far. This is the mid-sternal line. This distance is around 9 centimeter. This which cartilage? Fifth. This was second. Now, let me find out some easy way for you to understand if I draw it like this. I'm making again the heart over here. Okay. Try to understand. This was third costal cartilage. This was sixth. This was second. This was fifth. Understand? 3 and 6 difference is 3 only. 2 and 5 difference is 3 only. 3 costal cartilage difference. These points over here are just around 1 centimeter. Could be 0.8, 0.9, 1.1 centimeter. So it is around 1 centimeter from the midline or from the sternal margin, not midline, from the sternal margin. Suppose this is sternum over here. Let us try to draw the sternum also. Third right over here. So give me a second. Yeah. Okay. Understand this. So these distances over here are roughly around approximately, I'm saying 1 centimeter, plus or minus 0.1, 0.2 centimeter. So remember 3, 6, 2, 5. And this 3, 6, and 2 are very close to the sternal margin. This over here, this apex part over here is around 9 centimeter from the mid-sternal point or mid-sternal line. This is the region of the apex of the heart where we feel the left ventricle. Okay, where you feel the red left ventricle or cardiac impulse over here. So remember 3625 number. Now, if tomorrow a patient comes to you with a stab or a gunshot wound just lateral to the right-sided sternal margin at fourth cartilage, fifth cartilage, depth of around say 5-6 centimeter, you know, okay, the right border of the heart might be at risk. Suppose there is a stab injury, suppose 7 centimeter from the sternal margin, you know, okay, heart is probably saved. Could be injury to pleura, lungs, and fine, but heart is probably saved. Are you getting a point? Okay. Now, heart borders again, upper border. Yeah, upper border, obviously, we have to join points number 1 and 2 over here. Lower border joins these 2 points. Right border, okay, over here, left border, okay. So, yeah, these are the 4 borders that you can see. Now comes the point as the pulmonary valves. Where are the pulmonary valves? Now, this is better understood once you start to auscultate through the stethoscope and auscultate about the heart murmurs. Because here is one point, and this is very, very important for your future next PG, NEET PG questions. Because if you have gone through recently concluded any exam, any national level exam, be it your FMG or NEET PG, INI-CT, you will see questions coming from this topic. Let me tell you over here again, making the sternum, because the bony landmark in the thorax is mainly sternum and ribs. That is the only bony landmark, right? All the walls of the heart, their surface marking is behind the sternum. It is behind the sternum. How many walls are there? 4 walls are there. We have pulmonary valve, we have aortic valve, we have mitral valve, and we have tricuspid valve. These are the 4 valves. Okay. Just for some of you, just brushing through, pulmonary valve is the outflow of right ventricle. Aortic valve will be outflow of left ventricle. Mitral will be between left atrium and left ventricle. Tricuspid is between right atrium and right ventricle. And all these 4 valves, their location, their surface anatomy is behind the sternum, Now, you are suspecting some heart problem in a child or a teenage or an old patient also. If you put your stethoscope over the sternum, you won't be hearing anything because this whole bony structure, you have the sternum over here. How will you feel? Or you're not able to hear? Therefore, the second thing which is discussed here is the auscultatory point. Auscultatory points are never over sternum because you won't be hearing much good noise over the sternum. So auscultatory points are different. That also we'll discuss. Auscultatory points will be somewhat over here, some will be here, some will be here, some will be here, some will be here, like this. So auscultatory points are away from the sternum, while actual surface marking of the valves is behind the sternum. This is point number 1. Now let us see. Okay. What are they discussing? Heart valves. Okay. A pulmonary valve, horizontal line 2.5 centimeter behind the upper border of an adjoining part of sternum. This is the area for pulmonary valve. Aortic valve behind left half of sternum at the level of, so they are all going behind the sternum. Mitral valve again behind the left half. So you can see the word behind over here. Let me find out the highlight behind. Okay. These are all behind sternum or behind some cartilage, behind sternum, and again behind sternum. All these 4 walls actually behind the sternum, but that is not of clinical use because you are not able to do anything over there. Only if you are a cardiac surgeon later on and you open up the heart in an open heart surgery, then only obviously you will see. But clinically, they are not that important. What is important is the other thing, that is auscultatory area. This is where you are going to put your stethoscope to hear for the heart sounds. I hope you are understanding my point. Okay, this is where you have to put your stethoscope. This is different over here. Now, these are the things which you should know. These are things that you should know over here, all these 4. And let me put it out over here. Now, suppose this is the sternum. Let me see an empty space somewhat. Yeah, right over here. This is the sternum, manubrium, body, and this is the xiphoid process. Let me simply write over here M for mitral valve, T over here, or can be over here also tricuspid valve. Okay. Then what we have? Yeah, pulmonary valve over here and aortic valve over here. These are the auscultatory areas. Remember it by MTP. I used to remember it by MTPA, M, T, P, and A. So mitral valve, we normally hear about the abnormality in mitral valve at the cardiac apex. Remember, 9 centimeter fifth costal cartilage. Tricuspid, we just hear at around the lower part of the sternum, both the sides. Pulmonary valve, we hear on the left second costal cartilage. Aortic auscultatory area is on the right sided second costal cartilage. First understand this, then I'll tell you why there's so much of difference. Pulmonary valve, second left intercostal space near the sternum. So this is the area for pulmonary valve over here. Pulmonary valve. Aortic valve, AOR, second on the right side. So difference is basically very small. Second left and second right at the top. Mitral left fifth intercostal space 9 centimeters. So it is at the apex. And tricuspid is left of the lower part of the sternum near the fifth space. Now, why are they different? The point over here is because just I've told you 5 minutes back that their surface anatomy is behind the sternum. But where we actually hear is totally entirely different. The reason of this is, see, we can't hear over a sternum. But if suppose these are 2 chambers, let me just try to tell you something over here. Suppose this is chamber, these are 2 chambers, okay, chamber A and chamber B. And between them, you have a normal valve over here. So blood is normally going from here to here. Fine. Now, if there is a valvular abnormality, then obviously the blood which was going normally will not go normally. It will strike the chamber B. So you are going to hear the sounds where there is abnormal striking of blood on the wall of the heart from inside. Therefore, if you see about the pulmonary, this is suppose imagine the heart, the pulmonary trunk will come out like this. Then it divides into both right and left side. That is a different point. But when it comes out like this, the blood is actually coming like this. So we hear it on the left side second, because it is going above. No, it is not coming down. It is going above. So for pulmonary valve auscultatory area, it is left side second costal cartilage. But if you look at the aorta, the ascending aorta will start like this, and then it forms a arch. So if there is any turbulence in the aortic wall, the blood is going in this direction. So the aortic area is right side second costal cartilage, not left. The mitral valve is actually between left atrium, left ventricle. Yes or no? This much we should know. Between left atrium, left ventricle, we have which valve? We have the mitral valve. Now, if there is a problem in the mitral valve, the blood which was initially normally going from LA to LV will now go have some turbulent flow and strike the LV. Where will it strike? It will strike at the apex. Therefore, this is the place at the apex where we hear the mitral valve. These are all practical situations. Same goes for tricuspid also. Okay, so auscultatory areas are different. Cardiac apex we discussed already. It is again 9 centimeter from the midline, left intercostal space. Now coming to the cervical pleura over here, apex of lung. Okay. Now, lungs over here. So in lungs, you have two things to see. Basically, it's a pleura and the lungs per se. So cervical pleura or apex of the lungs, where to see so surface anatomy. Pleura is basically divided into 3-4 names. Let us first have a brief introduction of it. We know we have two lungs over here. One is the right lung, one is the left lung. Right lung normally has 3 lobes, which are upper, middle, and lower. Left lung normally has 2 lobes, which are upper and lower. Upper and lower. And therefore, between these two, we have few fissures. Both lungs will have oblique fissure. So oblique fissure is present in both right and left lung. But as right lung has 3 lobes, so right lung will have an extra fissure known as horizontal fissure present only in right lung. Find this clear? Now lungs are covered on all the sides by pleura. There are two types of pleura. The one pleura which is covering the lungs is known as visceral pleura. So it is covering the lungs. It is actually glued or stuck to the lungs. So wherever the lung surface marking goes, the visceral pleura marking will go along with it. So viscera means an organ. So visceral pleura is stuck to the lungs. The other pleura which is clinically important is your parietal pleura. Is your parietal pleura. Now, it is slightly separated from visceral pleura. It is slightly different, slightly away from the visceral pleura, slightly away. And therefore, between these two, what is present is known as a pleural space or pleural cavity. Pleural space or pleural cavity is what we normally call it. Between the visceral and the parietal pleura. Pleural space or pleural cavity. And therefore, if fluid starts to accumulate over here, if the fluid starts to accumulate over here, we start to call it as pleural effusion, or we start giving different names. Pneumothorax, air, hemothorax, hydrothorax, like that. So in a nutshell, what we have seen is that, okay, suppose this is the, say the right lung, this is say the left lung. Imagine. Now, this purple color is the visceral pleura. What is this? This is the visceral pleura which is covering the lungs. Is it fine? And say this which color? This sort of yellowish color or brownish color is the somatic pleura. It is slightly, or parietal pleura, it is slightly away from the visceral pleura. Yes or no? Now, visceral pleura is actually glued to the lung, so we can't name it differently. But this parietal pleura, we can give it different names depending on the location. Once it comes close to the neck, we call this area of the pleura cervical, or this area of the parietal as a cervical pleura. Cervical means cervical vertebral neck. Once this parietal is covering the ribs, we call it as costal pleura. This pleura will be costal pleura. This below this side pleura is over the diaphragm. So this part of the pleura, we call it as diaphragmatic pleura. And this part of the pleura, let me highlight, this part of the pleura is towards the mediastinum. So we'll call this side pleura as the mediastinal pleura. For those who are not aware of mediastinum, don't worry, it will come as a topic, separate topic. So we have 4 parts. We have 4 parts of 4 names for the parietal pleura: cervical, costal, diaphragmatic, and mediastinal pleura. This thing understand. Why do we need to know the separate? Because Many times what is going to happen is sometimes there might be some fluid which is accumulated in the pleural space, not inside the lungs, but in the pleural space over here. Fluid might come and accumulate over here, known as pleural effusion and hydrothorax, and there are a number of diseases. It shouldn't normally always be a lung disease, but in many systemic diseases also, like diseases affecting heart, diseases affecting liver, kidney, and any malignancy. In those cases, the fluid might come and collect between the this visceral and parietal pleura. In those cases, you have to insert your needle over here and take out the fluid so that the lungs may get some area to breathe. Because if there is fluid inside this, the lungs will have less space to expand. Therefore, we should know the surface marking. Okay, so basic anatomy I told you, because just going like this to surface anatomy, not understanding what it actually refers to, will not make much of a sense. Now let's see some points of cervical pleura or apex of lung at the top. How to point some points over here. Let me change the color. Yeah. So mark the sternoclavicular joint. This you can actually feel. This is the sternoclavicular joint over here. Mark the junction of medial and middle third of clavicle and put a point 2.5 centimeter above the middle third of clavicle joined by a curved line. Understand this. This is very important in other situations also. Suppose I make the sternum over here. By this, I hope you can understand better. And this is, imagine the clavicles are attached to the sternum. This at point number 1 is sternoclavicular joint. Okay, so we have marked the sternoclavicular joint. Mark the junction of middle and middle third of clavicle. So divide the clavicle into 3 parts. Let's say these are the 3 parts of clavicle. So point number 2 is what? Point number 2 is between the middle and middle third. This is point number 2 over here. So this is point number 1. This is point number 2. And they're saying put a point 2.5 centimeter or 1 inch above the middle third of clavicle. So just measure around 1 inch. Point number 3 is over here. This is point number 3. It is 1 inch above the clavicle. And then join these areas with the red color over here with a curved line. This shows you the cervical pleura. What does it tell us? It tells us that we can feel the clavicle. This is right now, I am feeling my medial third of clavicle. So if I insert my finger like this deep over here, I should be aware that above the medial third of clavicle, slightly deeper inside, I will have my apex of the lungs and the cervical pleura. Here, it is an exposed part of the human body. So this area can be easily damaged by some penetrating injuries. And you should know just above the middle third of clavicle, deep inside, lungs can be injured. Which part of lungs? Because normally when we hear about lungs, no, we only know lungs are inside the chest cavity. But if you see an injury which is above the clavicle, if you don't know surface marking, you will, oh, this above the clavicle. No, lungs would be safe. If you outrightly say, no, above the clavicle, how lungs can be involved. It is 1 inch is not a very small. It is 2.5 centimeter. The lungs can be involved. This is the information that you should know. Okay. Okay. Now right-sided pleura, anterior margin. So we have the margins of pleura also called as right costo-mediastinal. Let us see that too. Deflection. So we have to take few points. Now this is the anterior margin. Now we are moving from cervical pleura, come to the anterior margin of the right-sided, because it is difference. There will be difference in your right and left. Why? Because in the left side you have the heart also coming into place. So it slightly shifts or it slightly displaces the anterior margin of the left lung or anterior margin of the left pleura. Let's see the pleura, right pleura anterior margin. We have points like right sternoclavicular joint, as we already saw, where the cervical pleura, then midpoint of sternal angle and xiphisternal joint. So it is, you can see it is going down up till the lower part of the sternum. I always understand it with the help of this sternum. So we have this sternum 3 parts. So watch which parts are they saying? Point number 1 is sternoclavicular joint. Point number 2 is midpoint of sternal angle. This is point number 2. Point number 3 is xiphisternal joint. This is point number 3. Join them. This is the right pleura anterior margin. This is the right pleura anterior margin. There will be difference between left. So let us see. Oh, the left also. What is the difference? 1 and 2 are same as right side. So what were 1 and 2? We have to draw it again. So 1 and 2 were, yes, the sternoclavicular and midpoint of sternal angle. Third, then after that, the midline of sternum at the level of fourth costal cartilage. So this is point number 3 around fourth costal cartilage. We have point number 3 over here. Then sternal angle of the level of 6. Now it moves slightly laterally outside to the fourth point. Okay, to the fourth point. In the right side, it was exactly in the midline. Now we can see over here also. Let me show you the image that I guess will be better for you guys to understand. Focus over here. Okay. Now, with this black color, I'm showing you. I'm putting arrows to the right pleura anterior margin. This is the right pleura anterior margin. And with say different colors, say red color, I will show you the left pleura anterior margin. And this is where the difference lies. Can you see the difference over here? This is the difference on. Because the heart actually slightly pushes. Fine. Okay, let us move more to the next point over here. Pleura inferior margin here, below also inferior margin. This light blue color is all your margins which are shown. These are the margins of pleura. And you can see this green color, these green colors over here, these are the margins of lungs or the visceral pleura. So this green color will be your lungs, and this light blue color will be your parietal pleura. If you understand this one, that is fine. And this space, let me show you that also with a highlighter and some darker color over here. Can you imagine this space? This is the pleural space, guys. This is the pleural space. This is the pleural space where the fluid can accumulate. That is known as pleural effusion, all the stuff. Okay, so inferior margin, 8th rib at mid-clavicular, 10th rib at mid-axillary, and 12th rib at lateral border of sacrospinal, 2 centimeter lateral to thoracic spine. What is that? So you have 3 pointers over here, mid-clavicular line, mid-axillary line, and this is known as paravertebral line. Lateral border of sacrospinal, that is lateral to the vertebrae. So inferior margin is going from anterior to posterior. Let me simplify this for you as you might be facing difficulties. Very, very important point over here. Listen carefully. Here I try to show you the gap, yes or no, between the lower margin of lungs and lower margin of parietal pleura. In case of lower margin of lungs, I can also see the lower margin of visceral pleura. Lower margin of visceral pleura. You can see there is a substantial gap over here. This gap is roughly around 2 ribs, which is a height of around 2 ribs. Now see, listen here carefully. It is very, very important, which I'm going to tell you for the next minute or two. This over here, I am writing the lower border. What lower border of what? Of lungs and lower border of parietal pleura. These are 2 statements, and we draw a line between them. We also draw a line between them. Let me make a bit more horizontal. Okay, line over here. Okay, lower border of lungs and lower border of pleura. Okay. Now 3 different parts which are at the mid-clavicular line. This is our clavicle over here. At mid-clavicular line, vertical plane. At mid-axillary line, between the anterior post-axillary border, mid-axillary line. And if you go behind, paravertebral. Paravertebral. That is where you have the sacrospinalis muscle, just lateral to the vertebrae is the whole point. So we are tracing the lungs and the pleura from front, from side, from back, basically from all the areas. Now the lower margin of lungs is, we can remember it by simply 6, 8, and 10. Just remember it, 6th rib, 8th rib, and 10th rib. So at the mid-clavicular line, the lower margin of lungs is 6th rib. At the mid-axillary line, the lower margin of lungs is 8th rib. At the paravertebral line, the lower margin of lungs is 10th rib. And there is a difference between lower border of lungs and pleura. Difference is, how much difference is? Around 2 ribs. So we add 2 over here. 6 plus 2 is 8. 8 plus 2 is 10. 10 plus 2 is 12 over here. So we just have to add 2 over here. 2 over here. Simple as that. So the Difference, vertical height difference between the lower margin of lungs and parietal pleura is around 2 ribs. But some of you might argue, but sir, lungs is a dynamic organ, right? We all know. We have around 15, 20 or 12 to 20 breaths per minute. Lung is always moving. All these points which are taken are in the mid-expiratory phase. So again, mid-expiratory resting phase. All these points are taken. Therefore, if you are doing a pleural tap, so you're taking the fluid out of a pleural space, you have to ask the patient to hold the breath for a few seconds. Else, needle is going inside and the person is breathing, lungs are moving up and down, it could damage the organ. This is done in resting phase. So 6, 8, 10. So therefore, in the beginning, you should know to count the ribs. Else, where would you count 6, 8, or 10? That is the beginning. Then you know, okay, you have counted 6. This is the lower border of lungs. Okay. Below this to 8th. Okay. So if you are going laterally to take the fluid out, if you have counted 8th rib, you know that okay, in the 8th space, in the 8th intercostal, 8th or 9th intercostal space, if I go on the side, I will have less chances to damage the lungs because there I will be in the pleural space directly. Similarly, on the left side of any side. So this gives us a good idea. This you should know. So this 8, 10, and 12 over here, they were for the pleura. As you can see over here, 8, 10, and 12, 8, 10, and 12 over here. They are for the pleura. So understand the difference of 6, 8, 10, and 6 plus 2, 8, 8 plus 2, 10, 10 plus 2, 12. Simple as that. Keep it in mind. It is very, very useful for you to understand. For your MCQs, for your general examination findings, these are very useful. Then comes the post paper that also will be a part of this only, right? So for the time being, guys, revise this much, okay? And do the other stuff in thorax also. In the next part, we will discuss some other. Don't worry if any surface marking is left. For example, abdomen we weren't able to touch. Don't worry. As we'll go on to the gross anatomy, again, we'll discuss this. This, whatever we have discussed, is just to initiate an interest in you guys about the topic surface anatomy. Simple as that. Let me tell you. As the gross anatomy will come into the picture, we are going to again discuss this. So this is all that is applied. In the beginning first session, I told that the main clinical application of the knowledge of gross anatomy is the surface anatomy. Okay, so that's all. And all the best. Keep on studying and revising. And any issue, anything which you like to ask, feel free to ask. We'll be more than happy to answer. Okay. So that's all from my side. Bye bye and good night. See you soon.